honor for me to be here this afternoon, and I'm very grateful to Tariq for asking me to come over. It's always indeed a pleasure for me to interact with my colleagues in the general practice who really who are the mainstay of the healthcare delivery system in our country and everywhere in the world. I think we in the hospitals, we see just tip of the iceberg. You are the whole iceberg, and it's extremely important really that we work as a team. This not only improves the patient care but also improves at least my knowledge. Whenever I interact with you, I am always wiser leaving these sessions than when I come in. Tariq asked me to talk about hepatitis B and just concentrate on hepatitis B. So I'll try to do that, but of course if there are any other questions, issues, we can discuss in the once again. Hepatitis B is one of the world's most common infectious disorder. As you know, hepatitis B formulates the bulk of the disease as far as the liver disease is concerned, and as far as the cancer is concerned. Approximately 315 million people right now in the world do have hepatitis B infection of one form or the other. So it's a disease of maybe 3.5 crore लोग at present all over the world. 5 से 10 lakh people, they die every year somewhere of hepatitis B related hepatitis or cirrhosis or liver cancer, because we know this is a cancerous virus, this causes cancer. So there is a lot of mortality and morbidity associated with this virus. If we look at the prevalence, it's different in the different parts of the world. If you can look in the Australia or in the developed world, the carrier rate of the prevalence of hepatitis B carriers is around 2%. In our part of the world, if you look at it, it's more than 8%. And according to our own study, which we did a screening in the dentists and also in the doctors, the carrier rate goes to above 13%. So it's one of the highest carrier rates in the world. Pakistan unfortunately belongs to an area which can say that they have the highest carrier rate in the world. So every 10 to 13 people out there walking, doing their work are positive for hepatitis B. Whether they have disease or not, but they are carrying the virus, and that is what is the extremely important thing, because they might not be knowing it, they might be contaminating others without knowing it, and this is the reason that the hepatitis B is so rapidly multiplying, and we are already in the epidemic of hepatitis B as far as Pakistan is concerned. If you look at the annual incidence of hepatocellular carcinoma, which of course one of the main causative factors remains hepatitis B, again Pakistan, India, Pakistan there is not much documentation, but if you look at India, neighboring India, and in Pakistan also, probably 150 per 100,000 population die of hepatocellular carcinoma. We are seeing it so commonly. At any given time in my unit in Mayo, we have about 2 to 3 hepatocellular carcinomas that we keep injecting with alcohol or do something about them. But it's an extremely common cancer in this part of the world. It is truly a global problem because there, as I said, there is a large pool of patients. There are serious consequences of this disease, and it poses a very significant economic burden on the individual, on the family, on the community, and then on the country itself. We do need urgent actions to address this problem. We do need to have immunization programs intact, and that is extremely important. I made feasibility for PASI, which is Social Security. I made feasibility for PIA, and I just told them, I said, if you vaccinate all your employees and their families, what you spend on the treatment of hepatitis B, chronic liver disease, and hepatocellular carcinoma, that burden is going to go away. So it's so cost effective to vaccinate somebody in Pakistan, because if you vaccinate everybody and you eliminate hepatitis B related diseases, then it becomes extremely cost effective program. Therapeutic intervention for chronically infected patients are required, because unless we do that, people are people will keep on dying because of this, and we need big education initiatives like we are doing now to prevent the transmission, increase the awareness about the disease, and go to the first line healthcare providers like you, and then to the public really, and make them aware that how far this is common, what is their risk, and how they can protect themselves. Hepatitis B virus causes loss of quality of life. You can just see one patient of chronic hepatitis B infection and you know the quality of life. Sometimes he has ascites, sometimes he's bleeding up a GI, sometimes he's in hepatic encephalopathy, and so on. The life expectancy just decreases by decades. 2 decades you lose if you are hepatitis B positive. And there is high lifetime costs associated with management of disease and sequelae of hepatitis B infection. It's very, very costlier affair. If you look at hepatocellular carcinoma, it's extremely costly disease to treat. We can treat probably 200 patients of tuberculosis with the same price that we treat one patient of hepatocellular carcinoma. And it has a lot of economic impact, direct impact, the patient cost, the treatment cost, and also indirect cost in the days lost because of this disease. Overall healthcare cost is about 3 to 4 times more if you are hepatitis B positive. It is going in your life, your budget should be about 4 times than your colleague who doesn't have hepatitis B. So it is an expensive affair altogether. Hepatitis B surface positive patients are more likely to be hospitalized, even if they are carriers, and they are supposedly they will have a longer stays in the hospital. And as the disease progresses, as it go on to affect the liver and causes chronicity in the liver, causes cancer, the healthcare cost increases exorbitantly. How is it transmitted? In majority of the patients, in our own study that we did at Mayo, around 50% of the patients has no history of blood transfusion. They have no history of sexual contact with a hepatitis B patient. So the main mode of transmission in Pakistan is still unknown. We don't know. We did a study in the triangle of Gujarat, from which and Gujranwala, from which a lot of my colleagues are sitting here, and Wazirabad, and we tried to look at the risk factors there, and the risk factors are very different than the risk factors which are documented. I think mainly still in the villages and the rural and some urban areas, still the deliveries are being done by dais, by local ladies who do not have concept of sterilization. And similarly, the circumcisions are being done by nais and by quacks and all these, and you know, they use, reuse, and then the ear and nose piercing of the girls. When they go in their innocence, they don't even know that they are going to have an ear piercing, but they are going to end up having hepatitis B for the rest of the life. Similarly, tattooing, you know, these things are very unusual globally, but very, very common, and they are very specific to our part of the world. And one needs to, really, I always say, one needs to respect the integrity of the human body. Once we invade integrity of the human body through a tattoo, through a prick, through a syringe, through a drips, and unfortunately it's very common for our patients to have drips. They don't get satisfied. You know, even my own servants, even our ward servants, they come up with us, it's ye badi garmi ho gayi hai. Only yesterday one of my bearer saying कि सर बड़ी गर्मी हो गई, मुझे पैसे दे दें. मैंने कहा पैसे किस लिए दे दें? जी मैंने ड्रिप लगवानी है जाके. You see, and it took me half an hour really to convince him that please, you don't need a drip. But somebody had told him that he had got better with a drip. एक हफ्ता गुजर जाता है जी, ड्रिप लगवा ली. You know, once you are invading the integrity of the body by whatever means, you see, you are challenging the nature, and then you might pay the price. You see, so that's what where the awareness needs to come in, that the human body need not be intervened unnecessarily. We give IV injections unnecessarily, IV vitamins, there is no role. Non-steroidal anti-inflammatories we are giving injectable when they are not being given in any developed world. They are not even registered. You know, they have no role at all. Repeatedly we have been advocating this, but still this is rampant in Pakistan. Hepatitis B virus is present in all body fluids. It is a very wide distribution. It doesn't restrict just to liver or just to bile or one fluid. It is present in all the serosal layers. It is present in the peritoneal fluid, pleural fluid, bronchial fluid. You can measure it, and it's present in blood, of course. The most important right now in the world is vertical transmission, mother to child, perinatal. A positive mother is very likely to give birth to a positive child. Okay, the chances of getting a positive child is about 40%. Depends upon the technique. Early closure, clamping of the placenta does help and things like that. But the fact remains that in Southeast Asia and even in Pakistan, this is a very common mode of transmission. Then we have horizontal mode of transmission from one colleague to the other, from one partner to the other, from wife to husband and so on, by sexual contact. Contaminated blood and blood products. Thank God we are doing some screening in most of the centers, but still it is not being universally done. Still we are giving blood without screening hepatitis B. And if you have such a bolus of hepatitis B virus, the whole blood contains hepatitis B virus, then it's very, very difficult that the patient will escape developing the disease. He is bound to develop a disease. So when we looked at the history in our study of patients, some of the patients had a bypass surgery and they had a blood transfusion 4 years ago. Somebody had a roadside accident and had a blood transfusion. So I think it's crime as today to give an unscreened blood. Similarly, organ and tissue transplantation, and of course the very important is reuse of unsterilized needles and syringes. Even the speaker of the Punjab Assembly was admitted to Mayo Hospital, and it was in the newspaper, he was my patient, and he said he'll see the syringe before it was open, and there was blood marks in the syringe which was opened in front of him. Obviously the syringes are being repacked in Pakistan. Here we sell our contaminated waste. There are no incinerators in big hospitals like Mayo. There are no incinerators even in public hospitals and small hospitals. Okay, so the contaminated waste is sold by kilograms. Okay, this is a biological waste. This is a poison. And who buys it? If you trace it, which we did, it goes to the Band area, and there are factories which just wash it and repack it, and then again it ends up in the market. So it's a very, very difficult practice. We tried with the Environment Board and everything, but I don't think we have made a headway to it. Still those death dens are functioning, and still people are collecting the waste. When we started this program, incinerator program, it was very interesting that we said we'll incinerate the placentas and all this, and there was a huge resistance from the authorities, hospital authorities. We were doing it almost free, 1 rupees per kg we would incinerate it, and we thought, why there is so much hue and cry. Then we found out that the placentas even from Lady Wellington Hospital, Lady Aitchison, were being sold, and they were going to chicken feed, and they were using it as protein content. So these are the situation on ground right now, where we even do not want to give away 1 rupee per kg, but might spread hepatitis B or C, AIDS to hundreds. So it's a very bleak situation, and I'm glad that we are talking about it, and I hope we keep talking, and we talk about this to the patients, to the authorities. We keep writing in the newspaper. It might improve the ultimate outcome. In highly endemic areas like Pakistan, Southeast Asia, perinatal transmission, mother to child, is most prevalent. Around 90% of children born to infected mother will become carriers. Now this is very, very important to understand. If a child contracts hepatitis B, his 90% chance is there that he will end up having a carrier state or chronic liver disease. If as an adult, God forbid, we contract it through our professional reason, we have only 5% chance. 95% chances our immune system will clear it. Children's immune system, infant's immune system is not well developed to reject this virus. It doesn't produce those antibodies. It doesn't produce the IgM and IgG antibodies which will kill this virus. Okay, so they just keep on having the virus till they grow, and then they develop a disease. So if you want to ask me what will be the most effective immunization program, the most effective will be to vaccinate mothers when they are of childbearing age, and then to vaccinate all the children when they are born. Okay, that would be most cost effective, because you will be reducing the disease burden much more than vaccinating the adult population. So that is the priority area, because the children do not handle this virus very well, and they end up having 90% chance of developing this. Of course, in the West, in the industrialized regions like US, Europe, sexual transmission is the #1 factor. Individuals who are most at risk of developing hepatitis B viral disease are infants below 3 years, infants who contract this disease through vertical transmission, and immunocompromised individuals who are on steroids, who are on diabetics, who are suffering from renal failure, people going for dialysis, things like that. As I said, the most important thing is we must remember that the children are very vulnerable to develop disease once they contract it below 1 year. 90% infants will develop the disease. 50% of the children at the age of 1 to 4 will develop the disease, and there is a 25% risk of death by liver cancer if the patient is contracted this disease during childhood. So very, very high sequelae as far as children are concerned. What is the hepatitis B virus? It's a double-stranded DNA virus. I'll just show the picture of that. It belongs to a family of Papillomavirus, and it has 4 open reading frames. It constitutes high viremia, rapid viral replication, high infectivity, and it does integrate into host genome, and it doesn't produce direct cell toxicity. The important thing is why it is not like Streptococcus, why it is hepatitis B. Streptococcus occurs and our body clears it. Some other virus, influenza, occurs, body clears it. These viruses, especially the hepatitis C more than B, they are not that antigenic. They are very similar to our body fluids, okay? And the body doesn't mount that much war against them. They are not inducing that many antibodies. So what we do is we give interferons to induce antibodies, because interferons are natural mediators of inflammation. So we want to produce inflammation, and in the inflammation we are hoping that the virus will be cleared. So that is the main. Hepatitis C is even less antigenic. It doesn't mount that much challenge to the body. Body considers it that part and parcel of the system, so it doesn't produce that many antibodies to reject it. So that is, it does integrate into host genome, as I said. This is the virus, the legendary virus. If you can see, it has an envelope or the outer core, the lipid core, which you can see. The envelope is very closely bound, and this is the surface, and this is what is antigenic to the body. Okay, and this is what is hepatitis B surface antigen. It is the core outside the envelope. Okay, then the DNA, the hepatitis B virus DNA, the real building block of the virus is right there in the middle, as you can see, the open frames and the helix over there, and that is what DNA is, but that's what we are measuring. Then there is hepatitis B E antigen, which is the nucleolus envelope, the small envelope there, that poses E. And then against the core there are core antigen, which is inside the nucleus. So core antigen is very difficult to measure, so we measure core antibodies. Hepatitis B surface antigen is easy to measure because it is outside, so we measure that. We also measure the antibodies developed to hepatitis B surface antigen, and we also can measure E antigen in the lab, which is very, very important. And E antigen, since it's a nucleolar antigen, the positivity of it means the cells, the nuclei are rapidly dividing. So E antigenicity, if somebody is hepatitis B antigen positive, that only means that he is rapidly multiplying the virus and he is very infective. He is very highly infective case. When my house physician is pricked by a hepatitis B patient many times, every day it happens, the next question I ask, is the patient E antigen positive? Because if the patient is E antigen positive, then my doctor has very high chance of developing the hepatitis B infection. Otherwise, if the E antigen is negative, the patient is less infective. So that's the structure of the virus. And here are the frames that I just showed you. You can see the S envelope, which is pre-S1, S2 and hepatitis B surface antigen, core, pre-core precursor, E antigen hepatitis B core, which is inside the nucleolar cells. Then the polymerase DNA you saw right inside the membrane with open frames, and then there is X proteins which are present throughout the nucleus. These are the different genotypes of this virus. Hepatitis B has many genotypes. Now we have developed an H genotype also, but at least it has 7 genotypes. And Pakistan, according to our own study, as you can see, the genotype D is quite common, which is the subtype of it is AYW2, AYW3. Okay, that's the commonest in India, Pakistan and the Mediterranean region. But if you look at in Europe, US, there is genotype A is more common. Genotype D is more associated with chronicity. It's less antigenic, so it's generally causing more problems than in the West. Here are the events which you expect occurring during hepatitis B replication. How does this virus replicate or multiply? Here you can see if the E antigen is positive, then the supercoiled DNA and transcriptase is very active because all the activity is going on in the nucleus. And this is what E antigenicity means, that the replication, induction of the replication by DNA supercoiled type is very, very rapid, and that is how we develop double-stranded HBV DNA virus. And then of course the synthesis of the core proteins later on. Once the DNA has been replicated, the rest just follows without any problems. Spectrum of the disease, if you look at acute hepatitis B virus infection, 90 to 95% of the neonates will go on to develop chronic hepatitis B infection. 50% of the children below age 5 will develop chronic hepatitis B infection once they are infected. 5 to 10% of the adult population will only go on to develop hepatitis B virus infection. Out of these, again, about 15 to 40%, depending upon the dose of the virus, genotype, the mode of transmission, the age of the patient, and the comorbidities, whether he is a diabetic or not, depending upon that, the patient will go on to develop fatal progressive liver disease either through hepatitis C, the hepatocellular carcinoma and death, or develop cirrhosis, decompensated cirrhosis, upper GI bleeds, hepatic encephalopathy and death. However, acute B hepatitis we know can go on to fulminant hepatitis in about 2% of the cases, and it's very, very difficult. Then the mortality, if hepatitis B is producing acute fulminant hepatitis right in the beginning, okay, just doesn't go into chronic stage but develop acute liver insult, acute liver necrosis, then the mortality is very high, and 2% of the patients will unfortunately do that. The course of hepatitis B virus infection is, following the hepatitis B virus, the immune system does attempt to clear this virus. Some people develop acute hepatitis B infection. Hepatitis B infection may, in the majority of the cases, be cleared by our own immune system during acute stage, and we won't even know about it. Many times, about 80% of us do develop hepatitis B infection at some stage, and we don't even know. And then when we do the testing later on, although the surface antigen is clear, but surface antibodies are positive. That means somebody had been exposed before, the virus has been cleared, but he has developed immunity, so he doesn't need vaccination, in fact, if the surface antibody is positive. It begins in the beginning as immune tolerance phase. The immune system just tolerates it, and typically this lasts for the incubation period, which is around 160 days. That is the immune tolerance phase, that your immune system is not really rejecting it, it's just accepting the whole thing. The next phase is immune clearance, when your B cells become very active and starts producing antibodies, and that is when the real problem occurs, because these antibodies, when produced, they'll cross react with the hepatocyte membrane, and they will also destroy the hepatocyte membrane where your virus is harboring, and this war will start going on. The antigenicity at the hepatocyte membrane, because they'll not destroy the virus, they'll destroy the hepatocytes, and this is the phase, next phase, that people, again 90 to 95% will develop some disease but will clear it without any medical intervention. Acute infection then in some people might progress to chronic infection, and where immune system fails to clear the virus in 6 months. What is the definition of chronic liver disease? Anything going beyond 6 months, of course, is chronic. It's very clear. Anything below 6 months, you can have a reinfection within 6 months, but that is a reinfection. But anything persisting for more than 6 months would constitute a chronic liver disease. Between 5 to 10% of adults and 90 to 95% of neonates with acute infection develop persistent chronic infection. Duration of immune tolerance will depend upon the route of infection, whether the ALT is elevated or not, whether the liver is mounting a challenge or not, and the course of hepatitis B infection. Between 25 to 40% of all individuals chronically infected with hepatitis B infection will develop progressive liver disease. Once they have developed the virus, when they have got it for more than 6 months, about 50% chance that they'll go on to develop chronic liver disease. During chronic infection, there will be elevation of transaminases. Cirrhosis will be the end stage, and of course we know cirrhosis is not curable. It is a replacement of all the hepatocytes, the liver tissue, by the fibrous tissue which is not functioning. It's a replacement fibrosis, which we call cirrhosis. But certainly now, even we diagnose cirrhosis little late in the day, but still we can halt it, and there is evidence to some extent we can reverse it. In fact, so that's good news for people suffering from cirrhosis. Compensated liver disease is the liver cirrhosis with some residual liver function. We always, very, very important clinically to say your patient is in compensation or decompensation. And if somebody has ascites, somebody has edema, somebody has gone in encephalopathy, any form of encephalopathy, stage 1 to 4, he is definitely decompensated. Somebody with a very prolonged prothrombin time, very low albumin, that is decompensation. Okay, somebody with no ascites, no history of encephalopathy, maybe he has bled, doesn't matter. GI bleeding doesn't mean compensated or decompensated. That just means portal hypertension. There may be some liver function left. And somebody with a relatively normal prothrombin, relatively normal albumin would classify to be called compensated liver disease. Hepatitis B virus remains the leading cause of hepatocellular carcinoma all over the world, and death generally from severe liver damage and causing end-stage liver disease is common. These are the phases. As you can see, the tolerance occurs in almost every person in the beginning. Okay, in the way there are variants, certain variants where the tolerance doesn't occur but chronicity occurs, and as I told you, B and C type of genotypes is related with this. But the common wild type, in the beginning there is tolerance, then there is attempt to elimination, and then there is no resistance. In the beginning we have hepatitis E antigenicity positive, which means active viral replication. Okay, and later on the disease might progress, but patient become negative to hepatitis BE. That he is not replicating the virus that big, but whatever the virus is there is constituting the damage to the liver. What about the vaccination? My colleague had just talked about it, so I'll very quickly go through it. The primary objective of hepatitis B immunization is to prevent chronic hepatitis B virus infections, which results in chronic liver disease and death. By preventing hepatitis B virus infection, the major reservoir of transmission of new infections will be reduced. So as I already said, vaccination is very effective, very cost effective. Which vaccine, plasma derived, recombinant DNA, I don't get into that business, but any vaccine is better than no vaccine. basically when we vaccinate, and of course you know vaccination is for 3 months and the booster is required after 2 to 3 years. It is 1, 0, 1 and 2 months. Okay, so one injection for 3 months. Now we have, it's a new schedule that WHO has given. So you vaccinate today, then after 1 month, and then after 1 month, and then after 2 years. Now we know that in Pakistan the quality of cold chain of these vaccines is not very good. The efficacy is doubtful. So what do? I always vaccinate the people and ask them to get their hepatitis B surface antibody after vaccination, 6 months after. If that is positive and good titers, that means this patient is protected. I have vaccinated many patients, many people, not patients, and I have seen they have not converted. They are not, the hepatitis B surface antibody is not positive. Okay, and many times a doctor comes to me, he said, मैंने एक टीका लगवाया था, फिर भूल गया था, फिर ये हो गया, फिर the thing to do is do hepatitis B surface antibody. If the antibody is present in high titer, that means he is protected. Okay, so if the patient contracts the virus, a prick injury or sexual contact with a positive patient or some form of prick has taken place, then he needs a booster in between at the same time. If somebody is naive, somebody has never been vaccinated, okay, like our own house physician, and a house physician is pricked by a hepatitis B positive patient, the protocol is that we vaccinate that person, the doctor who has been pricked, but also give immunoglobulins at the same time. So the vaccination is a must in any case. Okay, even post exposure there is a vaccination. The mothers should be vaccinated before they are pregnant, and the child when it is born should be half dose vaccinated immediately whenever the child is born. WHO of course recommends that every EPI expanded program, national immunization programs must include hepatitis B vaccination. But so far unfortunately these have not been very successful. You remember always these companies like PIA ask me, should we do hepatitis B surface antigen of everybody and then vaccinate, because there is no point in vaccinating if somebody is hepatitis B positive. We made a feasibility and we think there is no need to do it, because you are wasting so much money into that. I say, okay, buy more vaccines. If you vaccinate somebody who is hepatitis B positive, it doesn't matter, it doesn't do any harm, but you have wasted your vaccine. Okay, vaccine used to be manufactured plasma derived from New York, people who were carrying hepatitis B used to, but now it's a recombinant DNA technology which is more sterile. So they already have antibodies, okay, to hepatitis B. So you are not going to do any good to them vaccinating. But doesn't matter if you vaccinate them, rather than doing hepatitis B of everybody and then vaccinating only the negative patients, that's going to be less cost effective. So I always say, if you are doing mass vaccination, vaccinate everybody. So coming to the therapy itself, what are the aims of therapy of hepatitis B virus infection? There are short-term goals, long-term goal, and there are ultimate goal. The short-term goal is that E antigenicity must be seroconverted. We must make them E antigen negative, okay, and we must get rid of the DNA and normalize the transaminases. So these are the 3 objectives that we have to achieve in chronic hepatitis B. Number 1, patient must not remain E antigen positive, so he is not infective, there is no active viral replication. Number 2, hepatitis B DNA must become negative, so that there is no DNA of hepatitis B there which could harm the patient, and you try to normalize the liver functions. These are the objectives. E antigen negative patients who are already E antigen negative, when you get them, they are already E antigen negative, because you will get many patients who are E antigen negative. What do? There the goal is to make the PCR negative and to normalize the ALT, because they are already E antigen negative when they came to you. Long-term goals are to prevent, stop, and if possible reverse cirrhosis. Okay, that is very, very important, that liver necrosis must be stopped so that there is no replacement fibrosis, and the we must stop the progression to hepatocellular carcinoma. The ultimate goal is to seroconvert the patient from hepatitis B surface antigen positive to negative. But that is not the immediate goal. You can wait. Okay? If somebody is hepatitis B surface antigen positive, he is just a carrier. He is not having a disease. So it's good to seroconvert, and of course then to prolong the survival if possible. How do we make the diagnosis of hepatitis B virus? To confirm hepatitis B virus infection, assessment of the stage of the disease, state of the disease, whether it's acute, whether it's resolved, or whether it's chronic. These three cases can be. It could be hepatitis B E antigen positive, E antigen negative, surface antigen negative, surface antibody positive. Okay, that means the patient had a disease and now it is resolved. Or a chronic stage where he continues to be hepatitis B surface antigen positive, or he may be E antigen positive also. So that means the viral replication is still going on, his immune system is not doing its job. And then assessment of the grade and stage of the disease, which is done not only by viral markers but generally by liver biopsy. We have a fear of liver biopsy, but we do liver biopsies almost 10 a day in our unit, and thank God there's been no problem. Liver biopsy have become extremely safe by the new techniques, by the new biopsy needles, and we don't admit these patients now. We just do it after 1 hour, we send them home without any problem. So it has become a very safe option as well. How to monitor the disease? We need to monitor the disease progression, and we must try to detect the hepatocellular carcinoma as early as possible. We screen these patients who are hepatitis B positive for hepatocellular carcinoma. So once they develop hepatocellular carcinoma, immediately we can act. We can either ask resection or do some treatment where they can be cured. Unfortunately, we get hepatocellular carcinomas once it's all over the place and we can't do much about it. But in the developed world, very commonly hepatocellular carcinoma is being resected. Here it's a rare thing because we diagnose it too late. And treatment, of course, to prevent the sequelae of hepatitis B viral disease. There are 3 steps to serological diagnosis. In the beginning, we do hepatitis B surface antigen, anti-hepatitis B core, okay, and anti-hepatitis B E antigen. These are the things that in the beginning we do. Then for the replication, this is acute infection, this is the replication stage, E antigen, and because at this stage hepatitis B virus DNA PCR will be negative, here PCR will become positive after about 2 to 3 months, and E antigenicity might remain positive. That means active viral replication. And then later on we do core antibodies, okay, anti-HBC, core antibodies, transaminases, prothrombin time, and IgM antibodies, because the virus might have been cleared but the damage still might be ongoing. Assessment of state of infection, we must ask this question: is the patient infected with hepatitis B? Practically, when the patient comes to us, is the hepatitis B viral infection acute or chronic? That's important because the treatment is different. What is the risk of this patient to go on to develop chronic liver disease or progressive liver disease and die of hepatocellular carcinoma? Whether there is active liver disease caused by chronic infection, so we can treat it urgently. So these are the questions we'll ask ourselves when we are faced with hepatitis B viral patient. Hepatitis B surface antigen is the first marker to appear in the blood. It appears about 1 to 2 months after exposure. And antibody to hepatitis B core antigen, again anti-hepatitis B core is detected early. IgM antibody persists for 6 months, IgG persists indefinitely. So if you want to know somebody was exposed to hepatitis B, you or me, 20 years ago, the thing to do is hepatitis IgG anti-hepatitis B core antibody. Okay, this will persist indefinitely, and the importance of this is somebody today comes to you with a liver cancer. You want to know liver cancer is developed because of exposure to any workplace or occupational or hepatitis B. So he has cleared all the virus, everything, but he will remain hepatitis B core antibody IgG positive. So you know that he had this infection and now he is having this marker which tells us the past infection here. Okay. Hepatitis B surface antigen, hepatitis B core antigen detected by radioimmunoassay or ELISA. Okay, IgM generally means recent infection. Okay, and IgG generally means infection for more than 6 months. If the hepatitis B chronic infection, acute or chronic, how do you know? Hepatitis B surface antigen will be present in both the occasion. Anti-hepatitis B surface antibody, hepatitis B surface antibody will only be present in chronic infection. Okay, surface antigen will get, but antibody, especially as I said, IgG means remote infection. Years ago the infection was. IgM means that recently, 6 months ago, he was infected. This is very, very important. As I said, E antigen, hepatitis B surface antigen appears first, then the E antigen after 2 months or so. Okay, and here you can see the liver enzymes go up and usually resolve and come to the baseline. Now over here, if you catch a patient after years, the liver enzymes may be normal. So it's a misconception कि जी इसके तो liver function कराएं वो normal है, इसको disease नहीं हो सकती. In fact, having a normal liver function in chronic liver disease is a bad omen, is a bad sign. I always say there is not enough liver left to be necrosed. So where will transaminases come from? Okay, so normal liver function does not exclude a chronic liver disease. The best liver test to do in chronic liver disease is prothrombin time and serum albumin, not transaminases. That is very, very important. That if you want to know कि यार ये underlying liver disease है कि नहीं chronic, do serum albumin and prothrombin. Don't just rely on transaminases, GPT and GPT, because they in any case become normal. Then anti-hepatitis B core, as you can see, remains positive and remains positive for rest of the life, especially IgG. IgM might clear up some years ago, couple of years, but hepatitis B core antibody, IgG remains positive. Then anti-hepatitis B surface antibody, okay, hepatitis B surface antibody remain positive. E antigen generally will become negative. In some patients who are immunocompromised, E antigenicity remains positive. So this is one slide which will give you overall summary of what we have been talking. And then of course there will be high viremia where TCR will be positive over here, okay, because the virus will be about 2 months after the exposure. You can see that. Hepatitis B surface antigen, PCR positive, E antigen, raised, fluctuating, abnormal, ALT, they all generally mean persistence of chronic infection, and these viral markers and the virus load can tell you how much virus is continuing to be there. Is the patient at risk of progressive liver disease once he has developed hepatitis B surface antigen positive? Presence of hepatitis V DNA PCR will confirm the hepatitis B virus infection, and potentially the virus is replicating, because you can quantify this. You can know the quantity of the virus logs, how many copies per mil are there, and you can monitor them after 3 months, the copies have increased or decreased, so you can do the quantification. Presence of E antigen generally means active viral replication. So these tests will tell you the chances or the probability of patient going into developed liver disease. What is the evidence of active liver disease in a patient who comes to you with hepatitis B? ALT, AST may or may not be helpful, but if you do the liver biopsy and see for yourself the necro-inflammatory liver disease, we generally score it. We say conoidal scoring system we use. The earlier means, conoidal 1 means, 0 means more inflammation, conoidal 5 means more fibrosis and less inflammation. So when we are trying to plan a strategy, develop a strategy of a patient, we say, oh, he has more inflammation, so he is more likely to respond. He has no cells left, he has only got fibrosis tissue, so what we are going to save? So we generally would not treat those patients with interferons and things like that. So a liver biopsy, as I said, is still one of the cornerstones of the management of chronic liver disease, and I think any good general practitioner, once little bit trained, under supervision, most welcome to come to our unit. I always say, Rana Sahab is there, we always try to interact very, very closely all the time, that they keep the patient, we come to them, we do the biopsies couple of times, our registrars can do it. So, you know, it's something that I think in UK and US, even the general practitioners, they are doing it on outpatient basis, and there's no harm in doing it after proper training. As I said, liver histological assessment is very important because it tells you the grade and degree of fibrosis, how much inflammation is there and how much fibrosis is there. Coming at the end to the hepatitis B virus treatment. Here you can see there are number of drugs available, levamisole and thamopsin, which are immunostimulants. Stimulate your immune system to clear the virus through threonine, and also there are immunosuppressive drugs like cyclosporin, prednisolone that can be used. Now, what is the role of prednisolone and cyclosporin? They are used when E antigenicity is negative, surface antigen is negative, but surface antibody is positive, and you know that this antibody is cross-reacting with your hepatocyte cellular membrane. There, steroids and immunosuppression might have some role, because you know that virus provoked this antigen-antibody response, and now the virus is gone, there is no active virus, but the antigen-antibody reaction is going on the cell membrane of the hepatocytes. So there you could have some degree of correction through the TC range. Then we have nucleoside analogs, which are also used for AIDS and HIV, like limivudine and Ediofur. We did a study with limivudine again a little while ago, and you know it stops the viral DNA replication there. Similarly, interferon, what is it doing? It is acting on three prongs. Number one, it is directly cytotoxic to the viral DNA. Okay, it is trying again to inhibit the replication of viral DNA directly by inducing killer cells. It also is producing inflammation in the body because it is an inflammatory mediator. So your cytokine production is increased, so your own immune system is being boosted up. So you clear the virus that way also. So it is acting in multiple ways in this situation. Thymosin, again, it enhances viral specific T helper cell response. As you know, in the immune system there are two cells. One is B cells, which I always call as lazy cells. They are lazy cells. They are sitting in the glands, in the spleen, in liver. They are not moving in the circulation. And then there are T cells. Lymphocytes are two types. T lymphocytes, it's oversimplification, but just to explain, they are two types, helper T and suppressor T. They modulate the function of B cells. B cells are producing antibodies. Okay, so once the antigen comes in, it is either the helper T which sends a message to the B cell to produce antibodies to clear it, or it is the suppressor T which is suppressing in normal situation not to produce antibodies against our own thyroid or pancreas or our own ovaries or testes, so we do not get autoimmune disease. So in this situation, the helper T, suppressor T